before I introduce myself again, although he's already done that, Sheila Manji works at the WHO Geneva office, and she's an expert in nutritional, in ECD, nurturing care for ECD. She supports the African region, and specifically 3 countries, Kenya, Tanzania, and Mozambique. For those who are aware of the nurturing care framework for ECD, it has 5 key components, and one of them is nutrition. So she's here to really just support us and to affirm the fact that nutrition is a key aspect, and particularly breastfeeding. So it's a pleasure that she's here with me, and I'm sure she'll say some good things when she goes back to Geneva. Sheila, you want to say hello?
Just hello to everyone. I'm really glad to be part of this. And as Makeba said, we're looking at how is nurturing care being incorporated into the work you're doing, and already breastfeeding is a key aspect of that. So looking forward to seeing what the growth and the experience in the country and in the regions.
So my presentation is really very simple because we're talking about the breastfeeding, the international code for marketing of breastfeeding substitutes. And the key word here actually is marketing. The code will speak about marketing. But a brief overview, we recognize that the central role that breastfeeding plays in the health of mothers and children, and in understanding the fact that aggressive and inappropriate marketing of breastfeeding substitutes, the World Health Assembly, which Kenya is a member, as far back as 1981, adopted this code. And we note that 40 years later, the companies continue to violate the established principles and place commercial interests before infant and population health. So the World Health Assembly resolutions have repeatedly called on national governments to enact the code. So this slide, in this slide, I think the most important thing to note is that the code's purpose is to protect and promote breastfeeding. That is fundamentally what the code is about. And how does it do this? It ensures proper use of the breast milk substitutes through appropriate marketing and distribution. And as I said, this journey began as far back as 1981. So that is the main purpose, to safeguard, protect, and promote breastfeeding. There is only one code. It began in 1981, and this slide shows you that it has gone through different modifications as evidence has been brought forward. And we just have a few infographics there that show really key milestones along the journey. So for example, in 1986, the code had clarifications and modifications related to supplies. Subsequently, for example, in 2005, issues around the risk of powdered infant formula. So the code remains one. All it does is, as the evidence comes forth, as the environment changes, as the strategies for marketing become more complex, the code then is updated, and you have clarifications and modifications. So it isn't a new document. It's been there from 1981. Now, what products are covered under the code? The code covers information related to safeguarding and protecting infants for formula milk for children less than 3 years. It also talks about issues related to food and beverages marketed as suitable or as partial or total replacement of breast milk. And so it informs about that. And around feeding bottles and teats. So again, it'll talk about anything that will need to protect because it's about marketing. So it's speaking about things related to marketing of bottles and teats, of partial milk that the marketers present as being better than breast milk or preferable to breast milk. And so the code includes this and speaks towards safeguarding against this. Who are the duty bearers? The manufacturers themselves and distributors of breast milk substitutes should know about the code and understand that really we're looking at the most important well-being of our children and saying that breast milk is superior. And if breast milk is superior, then they themselves, the manufacturers, also need to be able to take this up and market accordingly. Health workers, yourselves, and all the health systems, whether it is program managers, governance, leadership, in service delivery, you are duty bearers to ensure that this code is upheld. National governments, UN agencies like ourselves, NGOs, professional associations like the Kenya Paediatric Association, and other consumer industries, and more recently and very importantly, the media and creative industry. So why us? I think the question is, if it's not us, then who? And more importantly, why not the pediatricians, who really are the champions for children? So you don't look at this as a code that belongs to the government, to Madam Veronica. No, it belongs to each one of us. And she'll explain why Kenya actually adopted the code. So here we're going to look at a few slides that just highlight aspects related to the global standards in the code. For the code, clearly one of the things that come up is no free or subsidized supplies of breast milk substitutes. So all infant formula, feeding bottles, and teats used in the facility have been purchased through normal procurement channels and not received as free or subsidized supplies. Because once you give as free or subsidized, then you're promoting the use of the substitutes rather than promoting the breast milk. It's easier to give her the teat than to show her how to be able to position the child, breastfeed the child. So the code is protecting, it is safeguarding. And in safeguarding, it's saying no, we should only use normal procurement channels so that the formula milk is available, but it's a discretion of your doctors, your nurses, the healthcare workers to know who needs them. And it isn't just freely available to everybody and anybody. So we note here there will be no inducement to promote products offered to health workers, no free or subsidized supplies of breast milk substitutes, except through normal channels of procurement, no donation of equipment or services, because this is coercion. If I give you a NICU, then you're likely to feel obliged to allow your breast milk substitute, and really you're more biased or your things are compromised. No gifts or incitement to healthcare workers. So that is the code says that shouldn't happen. But I want to emphasize normal procurement channels. So your hospitals can actually procure, but it is based on your rules and regulations as to who then receives this milk. The code does not say don't procure. It just says procure and set standards of who is supposed to receive. And don't allow an environment that seems to uphold the use of the breast milk substitutes. The second standard is around displaying. So in the hospitals, in the health facilities, there is no display of products with logos of companies. Because as you know, if a mother sees a picture similar to that, then you're endorsing it. You're endorsing it, not necessarily verbally, but just by the very fact that you're in a health facility and you're in Dr. Muhudhia's clinic, then maybe he's saying that it's okay to be able to use this, even if he doesn't say it to you, but he's seen it. So the code says no display of products with logos of companies. So the facility has no display of products covered under the code of items with logos of companies that produce breast milk substitutes, feeding bottles and teats, or names of products covered under the code. This again is to still put breast milk at the highest pedestal level, to really, really promote it. And because we understand our population and our people, we must speak for the gold standard. And one of the ways is we don't display. So a policy that abides by the code, the facility should have a policy that describes how it abides by the code. And my colleague from UNICEF will speak a little bit more about the BFHI, the breast milk, the BFHI in the hospitals. And we'll notice that the recent guidelines actually insist that aspects of the code need to actually be displayed. So the facility then states how it abides by the code. It should have clear guidelines on how it's procuring the breast milk substitutes and not accepting support or gifts from producers or distributors of products covered by the code, and not giving substitutes. So it means no gifts, no samples, no education to caregivers on infant feeding and young child feeding in health facilities, no companies contacts with the mothers, and no use of health facilities to host events or companies. Why have we gone this direction? Because you give somebody a small space, they take over, and they're likely to then begin to market for the products. But remember our first slide. In our first slide, we said you are still allowed to buy the items, but then it is very specific guidelines of who receives these products. And I think the other global standard is capacity building. And I congratulate the Kenya Paediatric Association and efforts by Dr. Muhudhia and the Kenya Breastfeeding Association to really increase the capacity, the knowledge, increase the practice of health professionals in understanding the code and being the one to at least be able to explain. So you should be able to explain, why are we not marketing the products? Why don't we have logos around? The knowledge and understanding would allow you to then be champions for the code. And I know that there's also a lot of discussion around why isn't breast milk formula available. And sometimes you hear discussions and blaming the code. So the code does not say don't have infant formula. It doesn't say don't have breast milk substitutes, but it defines particularly where it safeguards and allows the ministry to then give the guidelines. And WHO has specific guidelines for infant and young child feeding. It has guidelines for preterm feeding. It has guidelines for low birth weight feeding. And those guidelines specify where you need some of the infant formula. So the two are actually different. The code just safeguards and protects breastfeeding. And it stipulates how this can be done. And on the other hand, WHO and the ministry also has guidelines on when, in some cases, you do need to have breast milk substitutes given. And I think that's an important point to take home, because sometimes there's confusion that the code has come to be able to block the process of getting breast milk substitutes. It perhaps can't be used for, the two are different. One just safeguards, protects breast milk, and says this is the number one nutrition that should be available for all children. And we know the many benefits, which I have not outlined here, that are really continue to be seen throughout the lifetime of an individual. What do we know? We know that in the African region, where we have about 42 countries, that WHO African region has 42 countries, we have only 9 countries with policies prohibiting the promotion of breast milk substitutes. And really, Kenya has been outstanding and is now mentoring other countries on how to do this. They're detailing the process, and I look forward to hear. I never get tired of hearing the journey that Madam Veronica and her team went through, but it took more than a decade. It took a really long time because there were many, many stakeholders, and there was a lot of resistance. So we are one of the few countries worldwide who actually have adopted. And just going back again to the fact that it's for promotion and safeguarding of breastfeeding. About 9 countries in the region have policies that prohibit the distribution. So some countries have picked certain aspects only. They've not picked everything. So they've just picked maybe just a distribution, but you're still allowed to advertise. And then we have 7 countries with policies with conflict of interest and healthcare responsibilities. So it's not explicitly stated what the health worker can or cannot do, the samples that they can pick, or the perhaps being able to benefit from manufacturers who give other incentives. So the slide is telling you that we've made some progress in the region, but we still have challenges. And remember, we have the highest number of children and adolescents, and the best way to protect them is to be able to ensure that they have the best chance in life by being given breast milk. So there are quite a number of tools that have been developed to support the code implementation. the code itself and all its legal jargon. We have the code and resolution. We have an online training that helps those who are interested to really understand about the code. We have a whole manual on frequently asked questions relating to the code that has been developed by UNICEF, WHO, and other stakeholders. We also have guidance in the implementation, and very often there are policy briefs being delivered, because the fight by the manufacturers is so strong, and it's twisted and turned in different ways. So very often you find that the UNICEF, WHO often have to keep on sharing policy briefs to make corrections on different things. And so there are a lot of information notes on very specific issues and even broader issues. And that will help you in your role as managers, in your role even in the healthcare workers, or even as you confront our colleagues, to tell them that certainly even your child, I would tell you to breastfeed. And we are only safeguarding what we know is best. I think one of the things is also monitoring. As you do something, you need to monitor it. We now want to have what we call net code. It's a toolkit to be able to try and monitor. Once you do a code, you make it legal. Operationalizing it is a totally different ballgame. And so to be able to understand how can countries then monitor how this code is implemented. And again, I'm sure Madam Veronica will touch on this. And I can tell you it's not an easy process. From all the information that's happening online, all that's being discussed in the different WhatsApp groups with the different supermamas and the rest, it's very difficult to actually keep track on everything that's going on, especially the misinformation. But the code tries to, the toolkit helps you to try and think as a country, as stakeholders, what can we do? How do we help to monitor it at different levels? The national level, the subnational level, health facilities. How do we empower the communities also to be gatekeepers and to also monitor and provide feedback? And I think Kenya is making some progress in this, and WHO is trying, in conjunction with UNICEF, to try and see how to support. But everybody has a stake, and I think everybody should see how can we help, how can we be part of this call for action. A lot of tools and examples, there are model legislations on how other countries have done this. We have an annual report on the status of how the code is being implemented across the world, across the region. So, in conclusion, what you need to take home: the purpose of the code is to safeguard, protect, and promote breastfeeding. I think if you only go back home with that, to me that's good enough. And the code matters more than ever now, because there is a lot of information, a lot of campaigns to try and sort of negate breastfeeding and make it not look like it is that important and that you can easily substitute it and get the same gains, which is not correct. Healthcare workers have a critical role to play. If you don't believe it, why should the mother believe it? If you don't believe it, why should the community believe it? You need to understand it, internalize it, really believe it, and then be able to preach about it. We need the ideas from you on how to implement it, how to ensure that we can track it, so that all children can benefit from breastfeeding. We should try to remain free from conflict of interest. I think that's where healthcare workers play a special role. Because if you become biased and are swayed the direction of the manufacturers, then it's very difficult for you to give an unbiased, honest, and truthful remarks. And enacting and enforcing the legislation, which is really the role of the government. There's a lot of resources we're going to share. I mean, there's in terms of links, and we'll give that to the track chair to ensure that KPA has it maybe on the website. An easy access for WHO. Even if you just Google some of these keywords, they'll come up. You have my contact. We can always discuss how can we further this on, whether it's through training or more information that you may require. Because for me, it doesn't matter. An individual, a group, an association, everybody needs to be part of this call for action, and I'll be more than glad to participate and help where I can. I think the next slide is still more, but most of all, I'd like to thank my colleagues who began this journey even before I joined WHO, Dr. Teshon Medesta, Dr. Asunta Mureithi, who was a colleague even, I think, to Prof. Ndwati at the department, Dr. Chabi, who's now in Nigeria, and other colleagues at Brazzaville who helped to put this presentation together. So thank you very much.